Hello, my dear friends. In the last class, and that was our first class, we discussed about hypoparathyroidism. Okay, we discussed about hypoparathyroidism. Now, today in this class, we will be discussing with the hyperparathyroidism. So, this is a very important endocrinological disorder. So, let us start. Okay, this hyperparathyroidism, we will discuss it in three parts. Okay, first we will discuss in what is known as okay first is primary hyperparathyroidism, second is secondary hyperparathyroidism, and third is tertiary hyperparathyroidism. Okay, so before going deep into this, what is primary, what are its findings, what is the pathophysiology, first we will discuss what happens in the hyperparathyroidism. In the hyperparathyroidism, in nutshell, what happens that the two parathyroid glands, like these are the two parathyroid glands in dogs and cats, they somehow become hyperactive. Okay, means what I mean to say that the chief cells inside the parathyroid gland, they become hyperactive. Okay, what are the reasons they become hyperactive? We will discuss that. So this will, when they become active chief cells, what happens that these hyperactive chief cells, they will start to release increased PTH. Okay, they will start to release increased PTH. So what are the reasons that these chief cells inside these parathyroid gland, they become hyperactive? Let us see. So the physiology, how this parathyroid gland works, as I discussed in the hypoparathyroidism case. So you all know that what happens there. So what will happen here, this PTH, increased PTH, okay, this increased PTH, it will go to the bones, and in the bones it will cause increased reabsorption of calcium in blood. Okay, this is the first. It is in the pathophysiology. Just we will discuss it a bit so that you will recall the things. Okay, you will compare it with hypoparathyroidism. So here what happened in the hypoparathyroidism, there was a decreased excretion of PTH, and that led to the decreased reabsorption of calcium in the blood. And in nutshell, what we found in the hypoparathyroidism, we found hypocalcemia. Okay, that. What was the other finding? Hyperphosphatemia. Okay, and decreased PTH. This was in hypo. Now what happens in hyperparathyroidism? There is increased PTH. Why? The chief cells are hyperactive. What are the reasons these chief cells become hyperactive? We will discuss that. And due to the hyperactivity of these chief cells, there is increased secretion of PTH that will stimulate the bones, the osteoclasts in the bones, and that will result in the increased reabsorption of calcium in the blood. Okay, means increased calcium in blood. First. Second, that it will act on kidneys. In the kidneys, it acts by two ways. PTH, it causes the synthesis of vitamin D, that. So when there is increase in PTH, it will cause the increase in this synthesis of vitamin D, and this vitamin D will go to the gut and will cause increased absorption of calcium in the gut. Okay, means it will also increase the calcium in blood. Okay, second one is this PTH, it directly acts on the proximal convoluted tubule of kidneys. There it causes the absorption of calcium. So when there is increased PTH, increased absorption of calcium in proximal convoluted tubule, that will also increase the calcium in the blood, means there is hypercalcemia. Okay, there is hypercalcemia. So this is the finding. So this is the first finding, means in hypoparathyroidism there was hypocalcemia. Here it is hypercalcemia, but please star it. Okay, because in cases in hyperparathyroidism cases, in primary, secondary and tertiary, we will discuss that. In secondary you will see either normal or decreased calcium. Okay, so this is not the consistent finding, but if you are asked in the exam, the finding in general, you are generally the finding in hyperparathyroidism, the lab finding in hyperparathyroidism is, if in the option it is hypercalcemia, go for that. Okay, so you have to remember, but not in every case of hyperparathyroidism you will see this hypercalcemia. What will happen to the phosphates? I told you that parathormone is important for dumping of phosphates from kidneys into the urine. So when there is increased PTH this synthesis, what will happen? It will dump the excess phosphate in the urine. Okay, so it will decrease. So there will be decreased phosphate in blood. Okay, do you understood it? I will repeat it. What happens normally when this PTH, it will act on kidneys. Okay, it will act on the kidneys, in the collecting duct of kidneys. What will happen? It causes the secretion of phosphates in urine. So when there is increased secretion of PTH, it will cause increased this secretion of dumping of phosphate in urine. So what will happen to the phosphate level in blood? It will decrease. So second finding is hypophosphatemia, okay, and increased PTH. So generally, if you are asked difference between hyperparathyroidism and hypoparathyroidism in cats and dogs, so you will go like this. One is, these are the lab differential diagnosis. One is in hypo we have hypocalcemia, in hyper we have hypercalcemia, in hypoparathyroidism we have hyperphosphatemia, here we have hypophosphatemia. Here it is decreased PTH and here it is increased PTH. So you understood. Now what is very important, let us discuss that. Primary hyperparathyroidism. What happens in the primary hyperparathyroidism? Let us discuss it thoroughly. Here in primary hyperparathyroidism, what happens that the problem of hyperactivity, hyperactive chief cells, it lies within the parathyroid gland. Okay, means the problem is in the parathyroid gland. So what sort of problem it could be? In dogs and cats, what has been seen, adenoma of parathyroid gland is the commonest problem. So this, whenever there is adenoma, cancer of parathyroid gland, what will happen? There will be hyperplasia. Okay, there will be hyperplasia of these chief cells. Hyperplasia. There will be hyperplasia of chief cells. Means the chief cells will be so much active. There will be hyperactivity and increased secretion of PTH. So this is the primary. What is the cause of primary hyperparathyroidism? One is adenoma parathyroid gland. Okay, you have to remember this. What is the second cause? Could be the second cause could be multiple endocrine neoplasia. Okay, multiple endocrine neoplasia. So this is also second cause of primary hyperparathyroidism in dogs and cats. This is of two types: multiple endocrine neoplasia first and multiple endocrine neoplasia second A. Okay, so this is the classification of this multiple endocrine neoplasia. What you have to remember, in multiple endocrine neoplasia, in general there is hyperplasia of parathyroid tissue. Okay, parathyroid gland tissue. So this is multiple endocrine neoplasia. In multiple endocrine neoplasia, first you will see three things. Okay, it is manifested by three findings. This men first, you can remember it by 3 P's. First is, in multiple endocrine neoplasia, first it will be always there will be pituitary tumor. Okay, secondly there will be pancreatic tumor. Thirdly there will be parathyroid hyperplasia. Okay, means in multiple endocrine neoplasia, first there could be pituitary tumor, pancreatic tumor, and also parathyroid hyperplasia. In men, second, it is manifested by medullary thyroid cancer. Okay, pheochromocytoma, and also parathyroid hyperplasia here also. So these are the two important causes of primary hyperparathyroidism. What happens in the primary hyperparathyroidism? The problem lies within the parathyroid gland. What sort of problem? It could be either adenoma parathyroid gland or multiple endocrine neoplasias. It could be men 1 or men 2. Men 1 is characterized by pituitary tumor, pancreatic tumor, and parathyroid hyperplasia. Here in men second, it could be medullary thyroid cancer, pheochromocytoma, or parathyroid hyperplasia. Now, what is most important, you have to remember that differentiates between the primary, secondary, and tertiary hyperparathyroidism. That is, in primary hyperparathyroidism, remember, kidneys are okay. Okay, means kidneys are okay. Kidneys are normal. Kidneys are intact. Okay, there is normal GFR. Okay, all other findings like creatinine, blood urine nitrogen, and urea, it would be normal. Okay, means the kidneys are neither there is AKI, acute kidney injury, neither there is chronic renal or CKD. So here remember, kidneys are normal. Now here what would be the in primary hyperparathyroidism, due to this hyperactivity of these chief cells of the parathyroid gland because of the adenoma and multiple endocrine neoplasia, what would happen? There would be increased secretion of PTH. Okay, what would happen? This increases, what would it do? It will go to the bones. It will go to the bones. It will hyperactive. It will hyperactivate the osteoclastos in the bones. And what will happen to these bones? it will cause a chewing of these bones and will tell the osteoclasts of the bones to reabsorb calcium. Okay, so there will be increased absorption of calcium in blood. Okay, first. Second, this increased PTH, it will act on the kidneys. Okay, in kidneys, what will it do? It will increase the, since kidneys are normal, what I told you here, kidneys are normal, so there will be increased vitamin D synthesis that would cause the increased calcium absorption from gut. So there will be increased calcium in blood. Okay, further in kidneys there will be increased absorption of calcium because the kidneys are normal, GFR is normal. This PTH will act on the kidneys. So first it will cause the increased synthesis of vitamin D, so there will be increased absorption of calcium from the gut, and here this PTH, it will act on the proximal convoluted tubule of the kidneys, and it would cause the increased absorption of calcium in the reabsorption of the calcium, and further it will increase the calcium in the blood, means there will be hypercalcemia. Okay, hypercalcemia. Now since the kidneys are normal, what will happen to the phosphates? Since kidneys are normal, what would happen to the phosphates? You all know that since kidneys are responsible for dumping of phosphate from blood to the urine, means to filter out the phosphate from blood to urine, these kidneys should be normal, and under the influence of PTH, increased PTH, there will be increased dumping of phosphates from blood to the urine. This will decrease the phosphate level in blood. Okay, are you getting me? Okay, so what will be the findings in primary hyperparathyroidism? Let me sum up. Okay, so let me sum up in primary hyperparathyroidism. First, there will be hypercalcemia. Okay, second, there will be hypophosphatemia, and third, there will be increased PTH. Fourth, there will be normal renal function. Okay, there will be normal renal function, means there will be normal GFR, normal creatinine. Okay, there will be normal blood urine nitrogen and normal urea, and specific gravity of urine would be normal, means there will be no proteinuria or albuminuria. Okay, when we will be dealing with the nephrology part, I will make you thoroughly understand about the AKI, what is acute kidney injury, it is pathogens and other things treatment, and CKD. Okay, we will be dealing with the classification of CKD according to the renal society and other things. So just bear with me, I will make you understand each and everything about this small clinic, small animal medicine. Okay, this is a very interesting one to get yourself acquainted with these things, because if you really want to have a good command on clinical cases, that too on the small animals, so you should have a thorough knowledge. Okay, so here I am, so just bear with me, and just do a favor, share with your these friends in your groups, but share with only these veterinarians. Okay, so I want veterinarians to deal with these cases, not others, other quacks. Okay, so my request is to share it with only your vet friends. So when we will be dealing with this, when we will be diagnosing, when we will go to the diagnostic part of this hyperparathyroidism, I will show you. You have to get a this renal panel also. Okay, you will tell this owner after getting the clinical signs. We will deal with the diagnostic part. So you will tell the owner, despite getting the calcium, phosphorus and PTH, you will tell the owner get a renal panel. Okay, why renal panel is important? Because it will help you in diagnosing whether it is primary hyperparathyroidism or secondary or tertiary. So what we found in primary hyperparathyroidism, there is hypercalcemia, hypophosphatemia, increased PTH, and more importantly normal renal function. Okay, how can you elucidate normal renal function? On normal GFR, normal creatinine, normal blood in nitrogen, normal urea, and specific gravity. Okay, and other, there will be no pigmenturia like albuminuria will not be there, and other things. So you will see that. Okay, so this is this primary hyperparathyroidism. So in now secondary hyperparathyroidism, please keep your concentration towards this. A bit difficult to understand, let me make it simple. Okay, secondary hyperparathyroidism. What happens in this secondary hyperparathyroidism? Here you have to remember the kidneys are not okay. Okay, the kidneys are not okay means not intact, means there is some sort of insult to the kidneys. Okay, like there is CKD, chronic kidney disease. Okay, now what will happen? Since this is the parathyroid gland, these are the parathyroid glands. Now what will happen here? In secondary hyperparathyroidism, there are two causes. One is either it could be a CKD patient, or there would be hypovitaminosis D. Okay, means either there would be deficiency of vitamin D, and either it could be a CKD patient. Now what will happen in this hypovitaminosis D? When the patient is hypovitaminotic D, there is deficiency of vitamin D. What will happen? You know that this vitamin D is very important for absorption of calcium from the gut. Okay, when it is deficient, the patient is deficient in vitamin D, there will be decreased absorption of calcium. Okay, means the patient will be hypokalemic. Okay, when the patient is hypokalemic, what will happen to the parathyroid gland? It will activate the parathyroid glands. What it will tell the parathyroid glands? Hey, where I am deficient in calcium, I am deficient in vitamin D. Since there will be decreased absorption of calcium, kindly regulate me. Okay, so this will activate these cheap cells, and it will cause the increased release of PTH. Okay, this is one cause. Means whenever the cat and dog is deficient in this vitamin D, it will cause the decreased absorption of calcium, or hypokalemic. Okay, there is deficiency of decreased calcium in blood. It will activate these parathyroid glands and will cause the increased excretion of PTH. Further, this is the first cause. Second cause would be the patient is CKD patient. Okay, CKD patient is there is insult in the kidney. What will happen? There will be decreased vitamin D synthesis. You know that because kidney is important for synthesis of conversion of 25 hydroxycholecholesterol to 125 dihydroxycholecholesterol. So when it is a CKD patient, there is insult in the kidney is not working properly, so there will be decreased vitamin D synthesis. So then it will go as this: decreased vitamin D, decreased calcium, hypocalcemia, and increased PTH secretion. Second is, since CKD, what happens in the CKD? You have to remember this. In CKD, what will happen? Remember, in CKD there is decreased glomerular filtration rate. Okay, you just remember it for now. We will discuss it very thoroughly in nephrology part. So here in CKD there is decreased GFR. When there is decreased glomerular filtration rate, what will happen to the phosphates? Since kidney is important for dumping of phosphate to urine, okay, when GFR is low, when kidney is not functioning properly, it will lead to the decreasing phosphate dumping in urine. Okay, there will be decreased phosphate dumping of phosphate into the urine. What will happen to the phosphates? It will build up in the blood, means hyperphosphatemia, means since phosphate is not removed through the urine, so it will go on building up in the blood. So when it will build up in the blood. So what happens that this phosphate in the blood, it will bind with the free calcium. Okay, this phosphate has the tendency to bind with the free calcium, so further decreasing the calcium level. Okay, so are you getting me? In CKD there are two pathophysiologies. One is decreased vitamin D, then it will go like this. Okay, further in CKD there is decreased GFR. Okay, that will lead to the decreased phosphate dumping in the urine, means building up of phosphate in the blood. Okay, in blood it will build up, and when it builds up in the blood, it will bind with the free calcium present, and it binds with it and causes this hypocalcemia. So when there is decreased calcium in the blood, it will further activate these cheap cells and will tell the cheap cells, please increase the PTH excretion. So this is very important. So in secondary hyperparathyroidism, kidneys are not okay, they are not intact. Okay, this is the pathophysiology of how this PTH excretion increase, how these cheap cells become hyperactive. In primary it was adenomas or neoplasias, but here the problem lies either hypovitaminosity or CKD. Okay, so what will happen here? Since here what you have to remember, that what will happen to the calcium. So here, since PTH in this secondary hyperparathyroidism, there could be either normal or decreased calcium. Okay, there could be either normal or decreased calcium, but increased phosphates. Okay, and decreased GFR. Okay, are you getting me how? Because you just see here there is deficiency of vitamin D, it is unable to absorb calcium from the blood, absorb the calcium from the gut, so causing hypocalcemia. Here phosphates, there is CKD, kidney is unable to dump the phosphates, so phosphates are building in the blood, they are increasing in the blood, and here these phosphates will further bind with this what we call this free calcium, and it will further decrease the calcium. So in either there could be normal or decreased calcium. So why I told you, and increased phosphates and decreased GFR. Okay, and there would be increased PTH. Okay, this is in case of secondary hyperparathyroidism, but in CKD patients. In CKD patients, In secondary hyperparathyroidism, you will see normal or decreased calcium, increased phosphates, and decreased GFR. What will happen to the secondary hyperparathyroidism with hypovitaminosis D patients? There will be normal or decreased calcium. Okay, what will happen to the phosphates? Anyone? Normal phosphates. Why? Because kidney is normal. Here only hypovitaminosis D means kidney is normal, it is dumping phosphates in the urine, and there will be normal glomerular filtration rate. Okay, so this thing you have to remember. In primary hyperparathyroidism, what we saw hypercalcemia, hyperphosphatemia, increased PTH, and normal renal function tests. But here there could be normal or decreased calcium, but increased phosphates and decreased GFR. And here in secondary hyperparathyroidism with hypovitaminosis D, normal or decreased calcium, normal phosphates, and normal glomerular filtration rate. And here also creatinine will be increased, blood urine nitrogen would be increased, and urea would be increased. Okay, these things we will discuss. There will be albuminuria also, so because it's a CKD patient. Now what happens in the tertiary hyperparathyroidism? In tertiary hyperparathyroidism, what would happen that it is seen in those CKD patients, chronic kidney disease patients, which are on hemodialysis. Okay, means they are on ESRD, end stage renal disease. Okay, when we go to the grading of this injury, kidney injury, we mainly say grade 1 grade on the basis of creatinine. When it is more than 10, so we can say that this is end stage renal disease. Okay, there will be also ultrasonographic change and all that. We will discuss that. So when the patient is ESRD, end stage renal disease, what will happen? You know that in end stage renal disease, what will happen that this kidney is not functioning. Okay, means there will be, this kidney is not producing vitamin D. Okay, and this kidney, what will happen that it is unable to dump a lot of phosphates in the urine, so phosphates are building. So what will happen here? The only source since PTH, if the PTH increased, if the PTH in CKD patients, what is happened there, those kidneys are on hemodialysis, means kidneys are not working properly, means there will be decrease of vitamin D. Okay, so when there is decrease of vitamin D, it would not absorb the calcium from the gut. Okay, so here in it will be, and there will be increased phosphates in the blood because it is not dumping the urine in this phosphates in the urine. Only way for the this in PTH to work is it will act on bones. Okay, and it will cause this in ESRD, since there is absolute hypovitaminosis D, and this hypovitaminosis D is equivalent to negligible, means this deficiency is so acute that there is almost no absorption of calcium from the gut. When there is no absorption of the calcium from the gut, means there is acute hypocalcemia. This acute hypocalcemia will trigger this parathyroid gland. Hey, since there is no calcium in the blood, kindly secrete a lot of PTH. So in ESRD, in tertiary hyperparathyroidism, there is increased secretion of PTH. Okay, when there is increased secretion of PTH, since this PTH won't work on kidney. Why? Because kidney is, it's a CKD, kidney is in ESRD, patient is in end stage renal disease, so it will work only on bones. So it will stimulate so much bones that bones will cause a massive reabsorption of calcium from the bones into blood. So in tertiary hyperparathyroidism, what you will find in nutshell, in tertiary hyperparathyroidism, the patient will be CKD patient or ESRD. Okay, so what will happen in the CKD, since there will be no vitamin synthesis, the synthesis of vitamin will be equivalent to negligible. So when there is acute this hypovitaminosity, it will cause the increase, there will be decreased this calcium absorption from the gut, and that will stimulate the parathyroid gland to secrete a lot of PTH, and that will only go to the bones and will cause the massive absorption of calcium into the blood. Okay, so this is the tertiary hyperparathyroidism. Okay, hope you understood this tertiary hyperparathyroidism. And in tertiary hyperparathyroidism, what you have to remember, there will be decreased vitamin D. Okay, there will be not normal GFR, since this is an end stage renal disease. There will be increased phosphates. Okay, and there will be increased calcium also. Why? Because this PTH is only working on the bones, and bones are reabsorption a lot of calcium in the blood. Okay, so what we found in this primary, let us recall a bit, so that you will get this, you will recall the things again. In primary hyperparathyroidism, we found hypercalcemia, hypophosphatemia, increased PTH, and normal renal functions. Okay, so what we found in this tertiary, we found hypercalcemia but hyperphosphatemia. Why? Because here in primary kidneys are normal, here kidneys are not normal. This is tertiary, and we found increased PTH, decreased vitamin D. Okay, and CKD means GFR not normal. Okay, so this will help you in diagnosing primary and tertiaries. Similarly with secondary, what we found in secondary, we found if it is a secondary hyperparathyroidism if the patient is CKD patient, so there will be normal or decreased calcium, hypocalcemia, but increased phosphates and decreased GFR. In secondary hyperparathyroidism, there will be normal or decreased calcium or normal phosphates and normal glomerular filtration rate. Okay, now remember, since this hyperparathyroidism, it is mainly seen in dogs and rarely in cats. Okay, rarely in cats. There are some case reports in that is reported in cats, and there is mainly found in older dogs. Okay, mainly 11 years of age, 6 to 14 years of age, mean age is 11 years of age, and there is no sex predisposition, means it can occur either in males or in females. Okay, because this sex predisposition plays a vital role in other endocrinological diseases like in diabetes mellitus. When we will be discussing this diabetes mellitus, mainly seen in female dogs. Okay, so I will tell you the reason why in female dogs, because these female dogs in diestrus, they secrete a lot of progesterone. Okay, and this progesterone has an antagonistic on insulin. So we will be discussing that is hypercortisolism and everything. So let's just remember, here is no sex predisposition. Okay, and in some breeds of dogs, it has been found that this hyperparathyroidism is hereditary, like diabetes in humans is genetic. Here in some dogs it is this has been found that it is hereditary. What is the breed of dog called? It's called Keeshonds. Remember this, maybe hospital examination. Keeshonds are, these are this hyperparathyroidism is hereditary in these patients. Okay, in these breeds. Now what our second concept would be in hyperparathyroidism would be complications. Okay, in what will happen in the complications, just remember, since I told you that mainly in primary and tertiary, what I told in primary and tertiary, there is always what I told in primary and tertiary, just there is always hypercalcemia. Okay, there is hypercalcemia also in primary, and there is also hypercalcemia in hypercalcemia in tertiary. Okay, and remember, whenever there is hypercalcemia mainly in primary and tertiary, what happens that whenever there is increased calcium in blood, it binds with the oxalates. Okay, and it will lead to formation of calcium oxalate calculi. Okay, so there will be urolithasis. Okay, or sometimes these calcium oxalates are also found in these kidneys, or there will be nephrolithasis. Okay, so this is one of the complications. Why? Because of the hypercalcemia, it will bind to the oxalates, and because when it binds with the oxalates, it leads to the urolithasis. Why? Sometimes you will see a case comes to you, either it could be a dog or a cat. The complaint would be there is frequent urinary obstruction despite catheterization, despite this medication. Okay, so there is recurrent urinary obstruction, and on the radiographs, when you interpret the radiograph, you will see stones. Okay, large stones. There will be nephroliths. So these nephroliths will be recurrent, and kindly, when you will find such type of case with recurrent uroliths in case of the dogs and cats, kindly evaluate it also for hyperparathyroidism. At least get a calcium, phosphate, vitamin D, and renal profile done. Okay, so this will help you in diagnosing the case. Okay, so this is you have to remember. Second complication is, since whenever there is in hyperparathyroidism, there is increased secretion of PTH. Okay, in all the cases there is increased secretion of PTH. PTH will act on the bones. Okay, so in the bones it causes the reabsorption of calcium from the bones, means in other language it is chewing the bones up. Okay, bones up. So there will be osteopenia and osteoporosis. Means in hyperparathyroidism cases you will see osteopenia and osteoporosis, and these cases with osteopenia, osteoporosis, or in hyperparathyroidism cases, you will see pathological fractures. You will see frequent incidence of pathological fractures. I mean, what we found in HPP, in the hyperparathyroidism cases, you will see recurrent urolithasis, recurrent nephroliths or nephrolithasis. You will see pathological fractures. Okay.